Thank you for the opportunity to share. So I'm just going to get started because we've been keen with time. So I also want to keep that. So my topic is going to be management of intrinsic tooth staining in a growing patient. And we'll try to look at how we try to preserve tooth structure, even as we try to restore aesthetics. I think that one has already been introduced already. And I'm a restorative dentist at Enamel Elegance, and I'm also blessed to work with a team of these dedicated ladies. I think for those of you we have had a privilege to serve you. At least I think some of those faces are familiar. Now we are in Westlands, and what I wanted to say, you might see some of the pictures that I'm showing here, because I've also been privileged to be working quite a bit with the Ivoclar products. So I'll be mentioning quite a bit of them. This looks like a very long discussion, but I'm going to make it very practical, because for me, usually what I want is when you live here today, no, you will not live today. When you leave after the weekend, on Tuesday morning, when you see a patient and you have a patient who has fluorosis, at least there is something that you have picked up that you are going to apply immediately. That for me is so we look at introduction, a bit of how we do our diagnosis. We'll see which composite to use, which bonding system, how to plan and execute our case. Isolation, of course, rubber dam has been mentioned, but I'll also show you something else. Then how do we prepare the tooth? How do we layer? Then finishing and characterization. I'll just pick up from where Dr. Alexander left it. Then polishing, maintenance, and I'll also show you some of the things that exist, which maybe some of you might be aware about. So, of course, dental fluorosis, I'll not dwell so much on the definition, because we already know it, especially those of us who practice locally, because it's something that we interact with every day. There is excessive fluoride exposure. Of course, there is going to be a lower mineral content. And so the tooth, especially the enamel, has a bit of porosity, or sometimes a lot of porosity. And that is where the stains are going to go into. So initially, the tooth comes into the mouth looking overly too white compared to the other teeth. And over time, you are going to find that those are the areas where the stains are going to start penetrating, and it's an intrinsic stain. Now, the biggest challenge that we have is that this looks like it's a problem that is on the rise. We did a study back in 2019, and this was the study that we did. And it was published in the Environmental Geochemistry Health by this gentleman here, who was the lead author, was a medical geology student, master's student in the University of Johannesburg that time. And I helped him as his local support to collect some data. And we found quite a bit of, let me just go back a bit. You can see, especially in Nakuru, and I know now this affects not just Nakuru, we've got Nairobi, we've got Baringo, we've got Kiambu, we've got Machakos, and also we've got Kajiado, where most of us reside. There is quite a bit of fluorosis. And you can see the younger age groups are the ones that are being affected more, mainly because of groundwater. Now, there is a lot of intervention that is going on with providing domestic filters, but these cases are going to continue to come to us. Now, when these patients come to us, what I want you to note especially is that these are young patients, these are growing patients. So I know there was a question about ceramics. Unfortunately, for these young patients, growing patients up to the age of 21, or even sometimes slightly more, we cannot do any ceramics. And again, we also are limited. We cannot do bleaching in most instances because of the young growing pulp, the pulp that is a very large pulp chamber and all the problems. So we are limited in terms of what we can do. So we are stuck with composites. And now, many times these patients will come to you and nothing much has really been done. I'll not go into the details of the TF index and all that. I'll just try to be very clinically oriented. Now, you will see patients like this, but sometimes you get patients who are like this. Now, this is the case I'm going to concentrate with. This is a case, Dr. Malenya, that you referred to my practice. And this patient was traveling to the UK for studies. And so they wanted something done, you know. So you will get that some intervention has been done before. And I don't know, this lighting doesn't do me a lot of justice, but I'll try and see if I don't know if I have a pointer here. But what you will see, particularly on that case, you can see after the continuous eruption. And this is why you can't do ceramics on such young patients, because as the tooth continues to erupt, you are going to get more and more of tooth structure. So what you are doing is a long-term provision. This masking that we are doing, it can't be a permanent solution. Now, this patient here, her name is Maya, and I'm going to share some of her pictures. I'll not show her face, but I happened to be her dad's teacher when I worked as a untrained teacher 20 years ago. So the dad was my student, and so he sent this girl after he went to a practice in Nakuru. Some work had been done. This was 6 months after. And you can see there is a lot of the composites have chipped off, and the girl was quite unhappy because she had transitioned to juniors, is it junior or senior school? Junior school, going to grade 7, and she had come to Nairobi and she wasn't happy. This, we were trying to tell her, Maya, smile, and this is all the much she could smile. You could see the composites have chipped off, and so we had to plan something for this patient, and masking was what we were going to do. I know my abstract reads something different. I think it was a typo in when they were being processed. I had intended to present 2 cases, one where we have done masking, and another one where we had a tetracycline staining, where we had to do root canal treatments and crowns. But I've realized over time with the presenting that when you keep jogging our minds between 2 cases, sometimes you lose us. So I prefer to just concentrate on one case and do it quite a bit of justice. So this is the intraoral pictures, and you can see quite that has already chipped. This has already chipped. There is quite a bit of staining that is already appearing there, a calculus accumulating. And when you see calculus accumulating, sometimes, yes, the patient is culpable, but also if the composites are not very well polished, you start to see this because it becomes a plaque retention area. So we had to make a decision. And also the other thing that you've got to be very careful when you are dealing with fluorosis is just try to look at the proximal areas, do these pictures, zoom them in, and you can also do transillumination just to rule out, because this is a different patient, but you can see that there is usually, especially where intervention has happened, if it's inadequate, sometimes there is proximal caries which you need to take care of alongside the masking that you're going to do. So usually the biggest question that people ask me, which composite do you use for masking? And what we want to ask is, what do you want to achieve? Now, as we have mentioned earlier, these teeth that have dental fluorosis usually have a very bright shade. It can't be even a B1. It's brighter than a B1. So luckily for these Ivoclar products, they usually have these bleach shades. And there is a bleach one. I think the Horn Healthcare people, they have a booth outside. You will just look at those composites and see them for yourself. They look quite bright. That is the only color or the only shade that will be able to match the shade that you have here. They also have an opaquer. The reason why we always want to use an opaquer is we do not want to remove too much tooth structure, okay? And I'll go to the preparation. Now, when you select composites, number one, there is the aspect of the shade, but the composite, you look at the filler particle. What sizes? Is it nanoparticles? What are they using? But ultimately, it adds down to the filler content, because I'll tell you the reason why that composite that you see initially failed. It has a very bright shade, but the filler content is very low. You place that composite on the tooth and you turn to get an instrument, and when you turn, the composite has slumped, it's moving. So I usually call it, not I call it, it's what it's called. It's called the slump test. You just take up a composite, you roll up on it on your finger, and you place it on your desk. If you see the composite sagging, that composite has a very low filler content and it shouldn't be used. So the dentists who used that composite previously, I will not mention it, but it's a composite that is locally available. It has a very low filler content. It looks very bright, but it does not meet this aspect of the filler content. So you have to look at the filler content. The technology that is used, especially nanoparticles, usually improve polishability of the composite. Now, the other thing I've mentioned about the shade is the optical properties. It should be able to mask what is under there, but it should also have aesthetic properties, especially the shade. Now, when it comes to manipulation, you need a composite that you will be able to manipulate. And ultimately, you will always see a lot of composites in the market. Now, people ask me, have you used this composite? Have you used that composite? The truth is, a reputable company will always, and there are a lot of reputable companies, so I don't want somebody to feel like I'm just pushing for. There are a lot of reputable companies, and you know them. They will usually put a lot of research and development into developing a good composite. So I'm a bit hesitant to just try every composite that I see, unfortunately. So I want to stick with reputable brands and ultimately also what works in your hands. Now, there is a whole shade selection here. I know Dr. Pap was sharing the IPS Impress because that's what is used in the US, in Greece, and all those places. Now we've got Tetric and Serum. It is what the brand goes by in the local market. There is the Tetric and Serum and the Tetric and Flow. So you can get these bleach shades, and now they also have this Tetric. They have the opaque shade. Okay, so you are able to select the shade that you want. Then the next thing that you have to think about is, how am I going to bond? So bonding is something that we can talk about the whole day, but I usually want to keep it simple. What bonding strategy do you want to use? Do you want to etch and rinse, or do you want to do self-etch? I'll tell you, many times we want to stick with these universal bonds, but because we want to keep our preparation within enamel, then we don't do just self-etching. Enamel studies have shown that for enamel, you actually have to etch enamel, and you are dealing with enamel that is fluoresced, so you've got to etch longer. So you have got to etch and wash it off. So make sure you invest in a good bonding system. So they usually provide this, there is the Tetric N-bond universal. It can come as a bottle, or it can also come as a pen that you click. I know the company says that the pen works very well and it's more economical. Sometimes I have to click it twice or thrice for it to come. So I prefer the bottle, but usually what I do at my practice is that I have a bond well where I put in the composite so that the solvent is not, because this, a good bond you will buy for 10,000, 12,000 shillings. So you don't want to waste it. So I make sure it's shaken well, just one drop into that well, and it's closed, and I'm able to use it for 2-3 teeth. And so I get maximum benefit out of it. So you've got to select a good bonding system, because this is the only thing that is going to hold your composite onto the tooth. Then the next thing that we are going to do, I think I jumped a slide there, is for you to plan how you are going to execute this case. Now I had Dr. Alexandra say 2 hours later, it was just one filling. Even masking, when you are going to do masking, I do not want to do masking 10 teeth in one sitting. It's not practical. So the way I usually arrange my case, and probably I'll invite you to do the same, you can see the first session, I just did the upper 6, okay? Canine to canine. That's what I did in the first appointment. These lights don't do me a lot of justice. These pictures look very nice here. But these lights are just, I'm usually very proud about how my pictures look. Proper, well curated, okay? Now the mic also is starting to pull. Okay, so so I first do my, what's going on here? So I first do my centrals, 6 to 6. Then the next thing I do 6, 6 on the lower. Then for the premolars, I have quite a bit of leeway to do all of them together. So this case was done over 3 appointments. Don't try to say you'll do all of them together, because sometimes it's very taxing, especially when it comes to finishing and polishing. And some of us use the words finishing and polishing like the same thing, but they are not the same thing. And I'll just show you that right now. Okay, so isolation, you know, I'm an apologist for rubber dam. So we try as many times as to use rubber dam. But since I've started preaching rubber dam in 2020, every time when we chat with somebody, do you actually use rubber dam? Doc, you know, so we try to use rubber dam. But I'll tell you, this rubber dam is the only proven way of giving you absolute. You know, it is isolation that is predictable. But you will get that there are some things that have come up that try to replace rubber dam. If you are using, this is called Optra dam, the one that is there. So it's basically having a frame and the rubber dam in one sitting. But you can also use Optragate, but what you'll get is relative isolation. Now, I know when you are working in an area that is not like the posterior areas, it's easy to get that relative isolation. Some studies have shown that you can actually, even the air that the patient breathes out that is moist is going to contaminate your composite. But I'll tell you, I've seen some composites where some bonding agents, especially the bonding agent that I've shown, even when it's contaminated with water, the adhesive bonding strength doesn't reduce significantly to be of clinical significance. I'm not giving a free and a blank check to say we don't need rubber dam. I'm just saying that in some cases where you find it difficult to use rubber dam, sometimes you can try and use something like Optragate. And this is also applicable when you are doing things like braces and all that. You are able to pull away the cheeks. Okay. So that's what we did. Then the next thing is tooth preparation. I think this is the most significant thing when it comes to tooth preparation. You will see my preparations remain within enamel. And I think Doc mentioned that the most predictable substrate that you can bond to is enamel. And that's why my title was saying, I am trying to preserve tooth structure more than give stunning aesthetics. I just want the aesthetics to be acceptable. When the patient reaches 20s, 25, then the ceramics and they look beautiful. But if you don't preserve this tooth until they are that age, if you cut so that you lay a composite and it looks beautiful, then you end up in dentine already. It will start chipping, and that tooth, you have already sent it down the restorative cycle. I'll tell you, all these procedures we did without giving the patient local anesthetic because we were within enamel, okay? And that tooth preservation is my take-home message. If you look at my preparation, I do not break the contacts. Of course, I was able to get caries removed in these areas where caries was already developing. In between the teeth, I just take my polishing strip, the polyester one. I just be not very aggressive, okay? So that I'm able to finish. But I do not break the contacts because these are not permanent veneers. These are temporary. You can see it's the same thing I've done on the lower. I'm basically preparing a window. I am not going subgingival because the moment you go subgingival, you start to have problems. So I'm just remaining equigingival in most areas so that then I preserve tooth structure. So it's basically preparing a window, very minimum preparation. The contacts, you can see like where the cusp tips of the canines are because I wanted to maintain the patient's canine guidance that she has. I did not touch those areas. So it's very minimal preparation. So if you forget everything else I say, this minimal preparation is the take-home message for me. The next thing is, so you can see, I'm just showing that you can see those canines, those contacts are not on those thin composites. They are actually on natural tooth structure, okay? Now, when it comes to preparation of the tooth structure, over time of practicing restorative dentistry, I've placed together a number of like 10 or 12 bars, which if Dr. Mua is going to prepare a tooth, and Dr. Dienya prepares a tooth and another person, you will keep on getting the same bars again and again and again. So I say this, I just call it the essential bar kit. So when you have these bars together, you have everything that you need to do tooth preparation. So you'll start with the regular bars first. Then after that, you will go to the finishing bars. Even the preparation, we use finishing bars. Why? Because we want to have a smooth surface. Now people say, why? But why are we etching? And we are saying you want a smooth surface. I'm talking about macro. Macro, I want it smooth. But at micro is when now you are going to have that smooth surface that you are going to use this yellow ring bars for finishing. Now, after that, I usually one tooth at a time, etching, everything, layering. It is one tooth at a time. So I use Teflon. People ask, where do you buy dental Teflon? No, this is not dental Teflon. We just use plumber's tape, okay? You just have to make sure. Usually what I do is I cut it, I can dip it in a disinfectant or even jig for a little bit of time, then I remove it, I place it in normal saline, and it's fair enough to be used in the patient's mouth. I just make sure I isolate the tooth nicely, even from etching, because if you don't isolate this, the next thing you are going to have is you layer your composite and you cure, and now the composites are stuck together. Then now you start going in with your polishing strips, then I have 5 minutes to finish. Thank you. I'm the one who was harassing people, so I've got to finish. So you can use this Optrasculpt pad to make sure you have a smooth layer, but you'll get that there are a lot of areas, and usually there are these instruments. They come as a set of 10, so you just layer your composites nicely. Make sure the final layer of composite is just one layer, because if you have more than one layers, when you cure here and you cure there, no matter how much you try to finish, it's not going to be smooth. So you can see we are layering one tooth at a time. And after that, then we go to finishing and characterization. So we are able to move, make sure that you do very good layering so that you reduce the work at polishing, finishing and polishing. So this is the final composite that we have placed. This one we have done our finishing, and there we have done our polishing. And how do we do this? This is for, that was for the upper, this for the lower. So I'm looking at these teeth from all angles and doing pictures, and she mentioned it, so my work becomes easier. I know where the transition angles are. And some of you have seen people drawing with pencils on the teeth. That's to know where the transition lines are so that you characterize the tooth to make it look like a natural tooth. The lower teeth didn't have much character. The upper teeth had quite a bit of character. So that's what we did. And when it comes to this finishing, usually you will start finishing with this red ring bars. After that, you go to the yellow ring, the discs, you use all this, and eventually then you move from there to there. Then the next thing you are going to use is now that is your finish. And this is something that you can do. You can watch videos, you can attend a course, and you will see how to actually do this finishing following those lines. Then after that, you get into polishing. Now, polishing also, you've got to get these polishing discs, polishing wheels, these silicone. And this, you will also see they have this. So I just go in and try to do very nice polishing. But after that, I have to give this tooth a high gloss. And usually I use something that is called goat's hair. I'm usually not sure whether it's actually goat's hair that is there. And I use composite polishing paste. Proximally, I go in with the polishing strips. I just make sure that everything is clean, no overhangs, nothing. Then you move it from there and you get your composites looking like that. I think it looks very beautiful. I've been told now I have 2 minutes. So the other thing is maintenance. I will finish in time, I promise you. The next thing is maintenance. Please make sure you call these patients back every 3 months, every 6 months, and polish your composites again. And I usually charge them 2,000 shillings for each of the composite polishing. But what I wanted you to notice is this is Maya's smile when she came in. This is Maya's smile when she came in for review just last 2 weeks before. So I wanted to do some pictures and share. And what you can see is that her smile line is higher now. That time she didn't want to smile. Now she comes into the, if she's alone in the waiting room, I'll see she has selected her own music and she's doing this. You know, she's quite confident now. So it's just a small aesthetic fix, but it brings in a big difference in this girl's life. So there are quite a bit of other alternatives that are in the industry, whereby you have some composite veneers that have already been fabricated that you can use as templates. I've bought that myself and tried to use it. The challenge is they are usually golden proportions. And if I do a survey here, I think we have like 200 or something. only 2 or 3 of you or 5 or 10 will have those golden proportions. So when you use those, you find that it becomes a big challenge for you to actually reproduce the tooth forms. So that is the challenge. You can do it. It involves a lot of finishing and polishing. It reminds me something that I interacted with called Edelweiss veneers, and I found quite a bit a challenge with them. I'm coming to my last slide, I promise you, Doc. Which one was that? So there is that industry. I think I have another slide about that. Now, some people say these beautiful things that maybe it's only Dr. Maronga who can do because he has a master's in restorative dentistry. It's not true. This is my colleague, Dr. Kendi, that we work with. And we recently have a patient who was referred to me and she said, Doc, can I try to do the case? And you can see the patient is quite happy and she was able to ace this case exactly nicely. You can see how well the patient is smiling. 3 appointments, of course, she had to break her back about it, but it's very doable. The other alternative that we have in the industry, which I think Doc mentioned, is you do the patient's impression. There is a digital workup that is done, and from there, you use that. You can either build directly using the index that she mentioned, or you can do something that is called injection molding, which is the new thing that is in the industry. So I think that's how I roll. So I'm done here. If there is a question, you can ask.